Good morning. Our lecture today is about diagnosis and indices. How can you make a diagnosis for a periodontal disease?
Dental diagnosis should be first determined whether disease is present or not. Then identify its type, extent, duration, distribution, and severity. History. It is very important to take a medical history from the patients and should be explained to the patients because patients may omit several information from us that they cannot be related to their dental problems. The patient should be made aware. Dental history. Current illness. Some patients may be unaware of any problem, but many may report bleeding gingiva, loss of teeth, spread of teeth, with the appearance of spaces between teeth where none existed before. Foul taste and bad odor, bad smell may be a chief complaint. Intraoral radiograph survey should be consist of minimum of 14 intraoral films and 4 posterior bite-wing films. Panoramic radiographs are simple and convenient method of obtaining a survey view of the dental arch and surrounding structures. Casts from dental impression are useful adjunctive to the oral examination. They indicate the position of the gingival margin, if there is a recession, the position and inclination of the teeth, proximal contact relationship, and food impaction area. Examination of the lymph node. The examination of lymph node is very important. It is important to palpate the submandibular lymph node, the middle jugular lymph node, and the submental lymph node. Tooth wasting disease or wasting disease of the teeth. This includes erosion. It is sharply defined wedge-shaped depressions in the cervical area of the facial tooth surface. In the early stages, it may be confined to the enamel, but it is generally extend to involve the underlying dentine, as well as the cementum. Abrasion. Abrasion refers to a loss of tooth substances induced by mechanical wear, other than that of mastication. Abrasion results in a saucer shape or wedge-shaped indentation with a smooth, shiny surface. Attrition. Attrition is an occlusal wear resulting from functional contacts with opposing teeth. Such physical wear patterns may occur on incisal, occlusal, and proximal tooth surfaces. A certain amount of tooth wear is physiological, but accelerated wear may occur when abnormal anatomical or unusual functional factors are present. Abfraction. Abfraction results from occlusal loading surfaces causing tooth fracture and mechanical microfractures and the tooth substances loss in the cervical area.
Examination of the periodontium. Gingiva. The gingiva is keratinized mucosa that surround the teeth. It forms a collar around each tooth. The gingiva is typically coral pink in color. In darker skinned persons, the gingiva may contain a melanin pigmentation, so the gingiva appear more darker in color.
Gingival index. According to Law 1967, the scoring criteria involve three scores: 0, 1, 2, 3. For 0, there is absence of inflammation and normal gingiva. For score 1, there is mild inflammation, slight change in the color, slight edema, no bleeding on propping. For score 2, there is moderate inflammation, moderate glazing, redness, edema, and hypertrophy, and bleeding on propping. For score 3, there is severe inflammation, marked redness, and hypertrophy, ulceration, and tendency to spontaneous bleeding. Bleeding on propping. A periodontal prop is inserted to the bottom of the gingiva or the periodontal pocket by applying a light force, and it is moved gently along the tooth or root surface. If a bleeding is provoked after propping, the site examined is considered as a positive, and we give it score 1 because there is an inflammation. If there is no bleeding occur, we give it score 0. Calculus index. Calculus is mineralized dental plaque. Calculus index refers to the amount of calculus present on the tooth surface. There are 3 scores of calculus index. 0 if no calculus is absorbed. Score 1 for scattered calculus covering less than 1/3 of the buccal tooth surface. Score 2 for calculus covering between 1 and 2/3 of the buccal tooth surface with minimum subgingival deposition. Score 3 calculus covering greater than 2/3 of the buccal tooth surface and extending subgingivally. Destructive changes in the periodontal tissues. There are many signs for destructive changes in the periodontium. First, attachment loss. 2. Periodontal pocket, which should be more than 4 mm. 3. Tooth mobility. 4. Pathological migration of the teeth, and the teeth become fan shape in appearance. Dental pockets examination must include their presence and distribution on each tooth. Surface pocket depth, level of the pocket, if it is infra-bony pocket, supra-bony pocket also must be evaluated. Periodontal pocket is the distance from the gingival margin to the base of the pocket. For the assessment of the propping pocket depth, we should extend the examination for all the teeth and all the sides of the teeth. The prop should be inserted parallel to the vertical axis of the tooth and walked circumferentially around each tooth surfaces to detect if there is any pocket found. Clinical attachment level. The level of attachment, on the other hand, is the distance between the base of the pocket and the fixed point on the crown, such as cemento-enamel junction. Changes in the level of attachment can be the result of a gain or loss of attachment and afford a better indication of the degree of periodontal destruction or periodontal gain. Basic periodontal examination. Careful assessment of periodontal tissues is an essential component of patient's management. This basic periodontal examination is a simple and rapid screening tool that is used to indicate the level of examination needed and to provide basic guidance on treatment needs. Please note that basic periodontal examination does not provide diagnosis for the patient. We have 4 scores for basic periodontal examination, score 0 to score 4. And we can use the WHO probe for the diagnosis. 0 for no pocket more than 3 to 5 millimeter. There is no calculus, no overhang fillings, no bleeding after probing, and the black band of the probe is completely visible. While score 1, there is no pocket more than 3.5 millimeter, no calculus, no overhangs, but there is bleeding after probing. The black band is completely visible. For score 2, there is no pocket more than 3.5 millimeter, but there is supra and subgingival calculus. The black band is completely visible. For score 3, the pocket depth is between 3.5 to 5.5 millimeter. The black band partially visible, indicating pockets of 4 to 5 millimeter. For score 4, the probing depth is more than 5.5 millimeter. The black band entirely within the pocket, indicating pocket of 6 millimeter or 4. Whenever there is furcation involvement in the teeth, you should add a star for the number of score. For score 0, no periodontal treatment is needed. For score 1, you need to give a patient oral hygiene instruction. For score 2, you give the patient oral hygiene instruction, removal of plaque retentive factor, including orsoplara and subgingival calculus by scaling. 3, oral hygiene instruction, and because there is pocket, you should do a root planing for the teeth. For score 4, you have to do oral hygiene instruction, root planing of the teeth, and you should have assessed the need for more complex treatment, which may involve surgery. Whenever star is found, you should do a complex treatment and you should refer the patient to a specialist to do the remaining treatment.